Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. I wanted to put together a special episode because we are getting so many questions, and I had this great conversation earlier on an earlier episode with Dr. Troso Sandoval. And part of that episode, if you didn't hear the whole entirety of it, we actually get into a section where we talk about genetic testing and ctDNA. So I wanted to make sure that my listeners, you guys, do not miss this really important content. So enjoy the special, and welcome to the conversation.
Basically, there are 3 or 4 different tests that you would probably potentially encounter. One is genetic testing, right? And that's the traditional genomic hereditary DNA. And they can get that by a mouth swab or blood, right? And that looks for different genes that you may have inherited from family member, your mom or your dad, right? Like BRCA1 and 2 are them. PALB2 is another one. And it's also important to know that this day and age, when we do genetic testing for hereditary genes, it should be a whole panel and not just BRCA1 and 2, because there are several genes now that we know contribute to the risk of breast cancer that should be tested for. Second type is somatic testing, which is the tumor. So oftentimes, usually in more advanced cases or metastatic or recurrent cancer, we take a piece of the actual tumor and we take the DNA from that, because the DNA shouldn't be exactly the same as your genetic hereditary DNA because it made itself into a tumor. It started as your cell, but then mistakes were made in the DNA. And so the tumor has its own set of abnormalities in it that made it a cancer. And so we can sequence those and name them. And, Sloan Kettering, for example, has the IMPACT program. We test over 440 genes that we know contribute to cancer. Foundation One has a test. I think Myriad has a test. There are multiple companies. There are commercial companies that have it too. And most major cancer institutions will be doing this. But the importance of that is looking for specific changes or mutations, abnormalities in the DNA that we can target. So in the case of breast cancer, for example, we might be looking for a PIK3CA mutation or an AKT mutation, a P10 mutation, or an ESR mutation, for example. So an ESR mutation, for anybody that doesn't know, is a mutation or an abnormality that can develop in the tumor. It's usually not there in the beginning. It can be, but usually not. It more frequently will develop over time. So say a patient's on an anti-estrogen therapy for a couple of years and the cancer comes back. We test that tumor and we might find this ESR1 mutation. And what that means is the cancer has figured out how to grow even without estrogen being present. So the anti-estrogen therapies, I don't want to get too deep into that, but so we have other medicines that help treat like that. And that was very prominently explained and detailed in a bunch of different presentations at both San Antonio and at ASCO this year, how we have these new medicines that we use that once the tumor develops this new ESR1 mutation and becomes resistant to tamoxifen, Arimidex, Femara, Aromasin, we have other drugs, some are injectable and some are oral, that overcome that resistance. And so that's a really important thing for us to know. And then the third type of DNA testing that is being used more frequently in clinical trials now, it's not as much used in regular practice, is ctDNA, circulating tumor DNA. And what that is some people refer to it as a liquid biopsy, right? And so we collect a vial of blood from you and we can test and pull out different tumor cells and then sequence the DNA from there. And so that's one way, quick and easy, that sometimes we can pick up these ESR mutations in a patient that looks like the cancer is starting to grow. And we can try and catch it on this liquid biopsy by collecting this circulating tumor DNA. It has a lot of possibilities for using for surveillance. So say somebody finishes their adjuvant preventative treatments, and we can then test to see whether there's any circulating tumor cells in circulation. And if there are, a recent study has shown that it might increase your risk that the cancers come back and it's not really gone, even though the PET scan's negative or the blood work otherwise looks normal, right? So it's not really ready for prime time. So you can't all run out and ask for ctDNA testing or liquid biopsies, but there are clinical trials that are ongoing where we're monitoring and we're trying to figure out, what is the level of importance? How many cells does there have to be for it to make a difference? Can we jump in with a new treatment earlier if we find these cells and that sort of thing? So
that was so helpful. Thank you so much. For my own understanding, so what I love to do, especially when talking to medical professionals as well, it's like, okay, let me repeat back to make sure I understood, and then also to share the questions that I have, because you provided this great overview of 3 different types of DNA testing. And so when do people start asking for this type of test? So I gave the example, I got my my genomic panel initially to help inform the surgery options in the treatment plan.
Right. And just to clarify, that's your hereditary risk.
Hereditary risk. Okay. Thank you. And
Yep.
then the second one you were mentioning is when you're taking the DNA specifically from the tumor to see if there's any mutations within the tumor. Can that happen at the beginning, or is that usually after resistance to certain therapies have happened, or both?
It's right now, the standard way to use it is if the patient has metastatic cancer or recurrent disease.
Okay.
So it's not standardly done up front.
Mm-hmm.
There are some trials and some people looking at doing it for stage 3 patients, more advanced cancers, but in general, it's mostly standardized for metastatic cancer and or recurrent disease. Yeah. Regrowth.
Yes. The ctDNA has been a buzzword for a long time out there. And so I appreciate you, again, clarifying its potential and then saying that there's still a lot of clinical trials that people can participate in if they're eligible, et cetera.
I'm sure that there are plenty of practitioners out there. In fact, I know there are, because I've had patients come to me with the test results. I'm like, how did you get that? So there are practitioners that are drawing them. And I guess either the patient pays cash for it or somehow they get their insurance company to pay for it. But, the problem is, even when you come with those results, as I mentioned, we're not quite sure what to do with them yet. So, there was one study that was just presented in the past 6 months about, I think it was called the ZEST trial. And they actually looked at patients that had BRCA genomic mutations. So they had a hereditary BRCA. And after they completed all of their adjuvant treatment, they would run the ctDNA. And if they were positive, well, actually, it was randomized. Patients would either get niraparib, which is a PARP inhibitor, or they would get placebo, because and the reason you can get away with that, it's not immoral, is because the standard of care is still to do nothing, right? So that's how you give the placebo. But the PARP inhibitors have a special place in treatment for breast cancer that has a BRCA positivity. And so they looked at this. And so the patients that had positive ctDNA, the ones that got the niraparib, actually had a longer time until progression. And so, so it's very promising, and it looks like something, hopefully, that we're going to be able to start using soon, because everybody's clamoring for it. But, unfortunately, we have to do clinical trials because sometimes things don't always work out exactly like you think they're going to. It seems reasonable that if you knew that the cancer cells were there, that if you did something now, it would help prevent it from coming back in full force. But that doesn't always bear out to be true. And so we have to do the trials to make sure, A, that we're doing no harm, and B, that it actually has a positive impact. So
we're never really ever over the cancer. It is, some days in the front of our mind, some days in the back of our mind. But as I'm approaching my 8 years, eventually 10-year mark, I'm like, oh gosh, once I get to 10, does that mean it's going to come back sooner? Especially in this setting where we do see studies showing that, some of these dormant cells will wake up 20 years down the line. Right. And so it's like, yes, we're living longer and I'm happy, but no, oh gosh, I'm scared. Is it coming? How do we manage the anxiety?
You control the controllables, right? And so what are the things that you can do to make sure that you are the least hospitable host for the cancer to grow back again, right? And I don't mean, taking ivermectin, so to speak, but although there are protocols looking at that, right? What are the things that are in your control? Are you maintaining your normal weight? Are you eating healthy and balanced? Are you, checking your other health factors? Are you walking every day? Are you lifting, light weights so that you keep up good muscle mass? Are you sleeping 8 hours a day? all the little things that seem to not be like, you're like, oh yeah, I know that. But, I always would tell my patients that, especially when you've had cancer and then after you have cancer, the little things matter. Staying healthy, keeping up a strong, resilient mindset, moving forward, a growth mindset, we call it, right? That you can learn and adapt and move within your new circumstances and still live your life even maybe better than before, because now you're informed about what it was like to be a cancer patient, and look what you've done, right? And so, so much of what you do is so helpful to others, but in some ways it helps you move past it as well, because you're empowering others and yourself. So I know it's a little, it's a little unsatisfying for me to tell you to just eat well and exercise and get enough sleep and drink 8 glasses of water a day, but believe it or not, and don't smoke, and don't drink too much alcohol, or don't drink any alcohol, depending on who you ask. There's a lot to be said for those things. And so, that's what I mean by trying to stay in the moment and to control the things you can control.
Well, thank you everyone for listening to our little special and snippet. If you like this type of content, short, sweet, and to the point, let me know. You can send me an email at laura@survivingbreastcancer.org or find me on social media, Laura_Carfang on Instagram, DM me. Let me know what you think. Always innovating, always trying to get the best content out there to you guys. Love you. Thank you for listening. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400 plus programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.